acute stroke in the ICU. So, acute ischemic stroke will start first. Acute ischemic stroke is characterized by the sudden loss of blood circulation to an area in the brain, particularly in vascular territory, resulting in a corresponding loss of neurological function. Approximately 10 to 15 to 20% of acute ischemic stroke patients are admitted to the ICU. Admitting this patient in a specialized stroke unit will give better results for the outcome of the stroke. This is a diagrammatic representation of the circle of Willis, which is the brain blood supply. This is usually being asked in the question like MCQ, like oral questions. So I hope that anyone preparing for an exam in the intensive care or critical care to be ready to answer like these questions. How to assess a patient with acute ischemic stroke? First of all, we have to take full medical history from the patient to decide if this is really a stroke, to determine if the patient is still in the window period, to avoid potential complications of acute therapy. Then we have to make proper physical examination. We should assess the level of consciousness, cranial nerves. We have to check the pupils, the visual fields, eye movements, and facial muscles. Higher cortical centers, we should check the aphasia and the neglect phenomena. Limb power and ataxia, sensory examination, and reflexes, biceps, triceps, ankle, and meniscus. There are some emergency diagnostic tests that we have to perform: blood glucose level, full blood count, renal function test, cardiac biomarkers, coagulation profile, ECG. Then we will go for neuroimaging. We make the non-contrast CT brain, which is the most commonly used until now. CT angiography. MRI brain can be done, but it's more with subacute infarctions, and Doppler study of the neck. The National Institute of Health Stroke Scale. This is a scale done by the National Institute of Health in the USA. This examination can be performed rapidly and can be easily assessed and give reliable results. They assess the level of consciousness, the extraocular muscles, visual fields, facial muscles, right and left arm, right and left lower limbs, limb ataxia, sensations, language and aphasia, dysarthria, and any other abnormalities. So if our score is 0, there is no stroke. Score 1 to 4, there's minor stroke. Score 5 to 15, moderate stroke. Stroke 15 to 20, moderate to severe stroke. 21 to 24, severe devastating stroke. So usually the thrombolysis is recommended score between 21 and between more than 5 to 25, less than 25. There is some guidelines for the time goals for evaluation and management of acute stroke patients, put by the National Institute of Neurological Disorders and Stroke in the United States as door to physician time, 10 minutes or less, door to stroke team, 15 minutes, door to CT, 25 minutes, door to CT interpretation, 45 minutes, door to medication, 60 minutes, and door to stroke unit admission, 3 hours. As we say in the acute myocardial infarction, that time is muscles, here time is nerves. Deal accurately, deal fast with your patient, and do not delay your management for any reason. What's the early management that we will do to the patient in the ER or on admission? Control the ABC. We have indications for intratracheal intubation if we have low glaucoma scale, if we have severe respiratory depression or of loss of airway protective reflexes. We have to intubate the patient to protect his airway and to maintain his respiration. Control of blood pressure is very important first measures to be done for the patient. The current guidelines recommend permissive hypertension for those patients who do not receive thrombolysis. Antihypertensive treatment should be withheld if the blood pressure is less than 220 and 120, and less than 185/100 for thrombolysis patients. So don't be aggressive in treatment of blood pressure in chronically hypertensive patients, which can reduce cerebral blood flow and worsen the condition. Glycemic management, our target blood glucose level during endovascular therapy is 140/80, is from 80 to 140 milligram per deciliter. And the target in the ICU should be less than 180 milligram per deciliter. Avoid severe fluctuation in blood glucose. Hyper or hypoglycemia are having very bad results to stroke patients. We have to avoid or give prophylaxis against seizures, which can happen in 1 to 4% of all cases, and usually caused by large cortical infarctions. Temperature, we have target temperature of 37.5. We have to treat any source of infection because patient with high fever or high temperature in stroke patients have higher mortality rates. What is the differential diagnosis of acute ischemic stroke? Number one, intracranial hemorrhage, where the onset is usually during a hypertensive crisis. Symptoms progress within minutes, and there's an acute onset of headache and early loss of consciousness during the intracranial hemorrhage. Second differential diagnosis is hypoglycemia, drug toxicity, intracranial space-occupying lesion, encephalitis, and metabolic disorders. How to localize the stroke clinically? Stroke can be many types, like lacunar infarctions, which are usually preceded by TIA a few minutes before the stroke. It has insidious onset and progressive course. Systemic embolization is usually associated with history of cardiac problems. It has sudden onset with maximum severity at the onset time. Can be large artery thrombosis or embolism like middle cerebral artery infarction, MCA. It shows contralateral motor weakness and or sensory loss, where the face and arm are affected more than the leg. And aphasia will happen if the dominant hemisphere is affected, and there's conjugated ipsilateral eye deviation. This is a picture of a big middle cerebral artery occlusion with stroke, massive stroke. Anterior cerebral artery infarction, we have contralateral hemiparesis and or sensory loss. Here, the lower limb is more than the upper limb, with urinary incontinence. If you have posterior circulation infarction, which is the vertebral, basilar, or posterior cerebral artery, we will see ipsilateral cranial nerve palsy, contralateral motor and or sensory loss, cerebellar dysfunction, Horner syndrome, and behavior disturbance. What is the general management of acute ischemic stroke in the ICU? We have to fully monitor the respiration with possible intubation and ventilation, blood pressure and manage according to the targets. Cardiac monitoring, we'll do an ECG, we'll do biomarkers, echo if needed. Temperature, keep it below 37.5. Blood glucose, as we said, below 180. Seizures, we can use EEG for monitoring, and aggressive treatment of documented convulsions. The neuromonitoring, we will need regular neurological examination. CT brain should be repeated 24 to 48 hours after, while routine ICP monitoring is not recommended except in selected cases. Treatment of acute ischemic stroke will start with the reperfusion therapy. Thrombolysis happens with patient with moderate to severe deficit or worse. IV recombinant tissue plasminogen activator should be considered for the patients in the window period of 4.5 hours after the onset of symptoms. The dose is 0.9 milligram per kilogram, but don't exceed 90 mg. 10% of the dose should be given as bolus in 1 minute, to be followed by 90% of the dose as infusion over 1 hour. Patients after TPA should not receive antiplatelets or anticoagulation for 24 hours. The endovascular treatment, patient with large proximal cerebral artery occlusion who present shortly after symptoms onset within a 6-hour window should be considered for endovascular treatment, which will show good outcome. The indication and contraindications of thrombolytic therapy are very clear. Please, we have to follow them properly and strictly, because not following this contraindications can lead to devastating results. The contraindications like severe hypertension, like suggestion of any hemorrhage or in the brain or anywhere in the body, like upper GIT or urinary tract hemorrhage within the previous 2 or 3 weeks. Any active bleeding as acute traumatic fracture on examination, any bleeding disorder will give us a contraindication to not to proceed for the thrombolytic therapy. Which patient should be admitted to the ICU of stroke patients? If patient is intubated, ventilated, patient with impaired level of consciousness or any sign of brainstem dysfunction, patient with elevated ICP with cerebral edema, patient in status epilepticus, patient with massive stroke score with more than 17, patients with large MCA infarction, medial cerebral artery infarction, uncontrolled blood pressure for invasive monitoring to be admitted in the ICU, for organ support like patient with acute renal failure or patient with cardiac failure, for post-operative admission after decompression craniotomy. All these patients are the candidates for ICU admission. In the ICU, keep head of the patient in the midline and elevated 20 to 30 degrees. Avoid head rotation so as not to influence the venous return. And if sedation is needed, must be adequate to avoid sudden increase in ICP. Avoid big hemodynamic changes during intubation. And fluid balance should be carefully monitored to maintain eovolemia. Plus, of course, the general measures for care of comatose patient: eye care, mouth care, skin care, anti-stress measures, anti-stress ulcer measures, anti-thromboembolic measures like this. If we go to the second type of cases that we can meet, intracerebral hemorrhage. What are the causes of non-traumatic intracerebral hemorrhage? Chronic hypertension, vascular malformations, long use of anticoagulants, brain tumors, hemorrhagic conversion of ischemic area, bleeding disorders, liver diseases, CNS infections, and vasculitis. Management of intracranial hemorrhage, we have to go for imaging. Non-contrast CT can define the size, location, and intraventricular extension and the shape of the midline. We can go for CT angiography if needed. Serial CT scan should be done to determine the extent of the hematoma and to guide the treatment. The treatment of ICT can be very difficult in the presence of coagulopathy, so coagulopathy should be treated. We can use prothrombin complex concentrate or fresh frozen plasma according to the facilities in the institute that we are working in. And cautious and slow blood pressure reduction is advised. Don't give strong measures to drop the blood pressure suddenly, because it will lead to very poor outcome if it happens. The surgical intervention in patients with spontaneous intracranial hemorrhage are still controversial. But they said that small clots, brainstem hematoma, patients above 70 years of age, patients with low Glasgow scale are best managed conservatively. But cerebellar hematomas with mass effect and lobar hematomas with neurological deterioration should be surgically removed as soon as possible. Subarachnoid hemorrhage, this is the third kind of neurological patient that we can meet in our ICU. Subarachnoid hemorrhage is a neurological emergency with high mortality and morbidity. It accounts for 3 to 6% of strokes as a whole. The 1 month fertility rate is around 30%. And for those who survive, 1/3 of them will need lifelong care. 80% of subarachnoid hemorrhage is due to spontaneous rupture of aneurysm in the basal arteries. In severe cases, the ICP may rise to very high levels, approaching or even above the mean arterial blood pressure. Global cerebral edema causing widespread ischemic neurological injury may ensue and causes very poor outcome for patients with subarachnoid hemorrhage. This is a CT picture of subarachnoid hemorrhage. Normal ICP is 5 to 15 millimeter mercury. If it is, it's 5 to 15 millimeters mercury. If it mild increase 16 to 20, moderate increase 21 to 30, with severe increase if above 30 millimeter mercury. Cerebral perfusion pressure equals mean arterial pressure minus intracranial pressure, normally 70 to 100. If less than 50, it will cause neurological damage. Clinical picture of subarachnoid hemorrhage, it's severe intolerable headache, where the patients usually give this expression that this is the worst feeling he had in his whole life. There is neck rigidity, there is vomiting, there is seizures, there is altered consciousness. We have the investigation of choice is again the non-contrast CT scan. But a normal scan, particularly early, does not exclude the diagnosis. So in the presence of a typical history, a normal scan, lumbar puncture should be done. The presence of RBCs or their metabolites in the CSF is diagnostic of subarachnoid hemorrhage. What are the treatment goals of subarachnoid hemorrhage? Number one, maintain ABC, maintain cerebral perfusion, and minimize the risk of rebleeding and vasospasm. Rebleeding is prevented by aneurysm obliteration. Is the most important method of preventing rebleeding, either surgically or radiologically. Keep systolic pressure below 160. Avoid the use of nitrates as a method of control of blood pressure. We can use, because it can cause increased intracranial pressure, we can use labetalol or hydralazine as other options. Cerebral vasospasm. Delayed ischemic deficit from vasospasm is a major cause of morbidity and mortality in subarachnoid hemorrhage. Post-operatively, blood pressure may be allowed to rise to a higher level to decrease the possibility of vasospasm. How to diagnose that there is a cerebral vasospasm post-subarachnoid hemorrhage? Clinically, there will be reduction in the level of consciousness or new neurological deficit. Radiologically, we can diagnose it by angiography. Also, transcranial Doppler can be used in the evaluation of vasospasm. How to treat this vasospasm? The mainstay of treatment of vasospasm is induced hypertension. Volume expansion by relatively high saline intake from 3 to 5 liters per day. But the effectiveness of this hypertensive hypervolemia is still debated in some centers. So, anemia is associated with higher rates of cerebral ischemia. And if vasopressors are needed, we can use phenylephrine, dopamine, vasopressin, or norepinephrine. Control of seizures to prevent rebleeding of the unsecured aneurysm. Thank you so much. This is a very brief presentation of the strokes. Here you have two pictures of the first hospital I ever worked in and the last hospital I worked in, with 29 years different. Thank you so much. Hope it was a very light lecture, and see you soon.
Thank you very much, Dr. Amr. It is very concise, as you said. I have a question. There's one question about the score for stroke. How it is calculated? Again, please.
Again, please. It is the, we have multiple criteria: level of consciousness, the extraocular muscle movement, visual field, the facial policy and muscles, the right and left arm motor deficit, right and left leg motor deficit, limb ataxia, sensations, language and aphasia, and dysarthria. This, each one of them, it's a very big score. If I can share it with everyone later on.
Yes.
But and each point has sub points and score. At the end, it's calculated and giving us the number of.
Okay. I want to ask a question about the mechanical ventilation. How
Yes,
the mechanical ventilation between these types of stroke is different? In a patient with ischemic stroke, for example, a patient subarachnoid hemorrhage, intracranial hemorrhage, those who are working as intensivist, how they manage this regarding the CO2, regarding the PEEP level, whatever. What do you think about this? Does it differ?
First of all, we try to avoid high PEEP in neurological injury or patient with suspected increase in blood pressure, because high PEEP can contribute to the elevation of intracranial pressure.
Okay.
So we are trying to make it as small as possible. Second point about the CO2, of course, the hypercapnia or hypocapnia issue that to keep the patient in a state of normocapnia going less to the lower limit, but avoid decrease of the carbon dioxide less than 30 to avoid cerebral vasospasm. Is that what you meant, sir?
Okay, there another question, Dr. Amra. Is the nimodopine has a place in the management of cerebral vasospasm in a patient with cerebral hemorrhage?
Yes, it has been used, and it has been used for a long time, but there is no very accurate supporting evidence about this.
Okay, another question. What are the methods accepted to induce hypertension?
As we said before, there is the hypervolemic hypertension method, which is giving big volume of saline every day, 3 to 5 liters. And also if needed, we can use some vasopressors, as we said before. Okay.
Another point regarding the ICP. This normal value of the ICP is while the patient is supine or the lateral position or semi-sitting, this 5 to 15.
This is supine.
Supine. So this patient usually we put them in semi-sitting position or 30-degree.
Yes.
Right. So this. Yes. When or where exactly we measure the ICP? We can. It is from the ventriculostomy or from lumbar site. What do you think?
No, from the ventricles.
Yeah, I'm trying to open a way of discussion because there are some journals I know that they are here, and this very important for them. So from the ventriculostomy, did we you adjusted the position regarding whether the patient is in sitting or supine?
Yes, of course, we adjust the level of measuring going to the position of the patient. Usually keep these patients between 20 and 30 degrees head up position. And accordingly, we will adjust the level of the zero level of our measurement.
So the zero level will differ from right?
Yes, sir.
Okay. I think Dr. Amr Hashim has a question. Can you please, Dr. Amr?
Yes, thank you very much, Dr. Amr, for this very informative lecture. First question is, what's the role of the MRI? If this patient, when should the patient go for an MRI before thrombolytic therapy or before cardiac, before interventional endovascular radiology? And if the patient is stable enough to go, should he go to the MRI, and is it present in the guidelines at any point? And is the second question, is the window of 4.5 hours still 4.5, or has it been extended, or is there any do they strictly follow the 4.5 hours, or there is any deviation from this?
So about the 4.5 hours, until now, in most of the centers, it's being followed. Mm-hmm. Some centers now are discussing increasing it to 6 hours.
Yeah.
And especially if you are planning for endovascular treatment.
Okay.
About the MRI question, until now, the most important tool is the CT. Yes, if the patient is stable enough, we can proceed for MRI, but the MRI has some drawbacks, like the length of
Yeah, sure.
the time of the procedure,
Yes.
and many times we are being called to the MRI suite to anesthetize the patients. So these patients, who will be enjoying the anesthesia of this patient?
I know. We
Yes.
should always avoid doing MRIs for these patients, especially
Yes.
from our side. We don't like it.
Yes.
But
right.
sometimes the neurologist will ask for it if the patient is stable. All right. Thank you so much, Dr. Amr.
Thank you, sir. Thank you so much.
Dr. Amr, another comment or another question. Is there a role for colloid fluids instead of crystalloid in such patients?
I don't think so, no. It was never mentioned in the guidelines. And then usually we don't use colloid for head injury or for increased intracranial tension. Even now in all our work in anesthesia and ICU, we're going not too much for colloids.
Okay. What about the dexamethasone and mannitol? Still, they have a role in a stroke patient?
Dexamethasone, definitely no.
Okay.
Mannitol, it has a role only if there is brain edema, which at that time we're not usually seeing it in stroke patients except in a very late stages or very massive strokes.
Okay. Thank you. I think Dr. Walid will have a comment. Can you please, Dr. Walid?
So thanks very much for this very comprehensive lecture, as usual, Dr. Amr Safwat.
Thank you, sir.
It's just a few ideas depending on my work in here in Ireland. You may disagree with me completely. So we had few questions about crystalloids versus colloids. The colloids is not something homogeneous, so we can differentiate that into starch-based colloids and gelofusine-based colloids. So starch is known with its contraindication in all high ICPs, so it's completely contraindicated. One of the main contraindications by the FDA. So if it's traumatic brain injury or any high ICP, is one of contraindications to use the starch. But while gelofusine, I had seen it used in a lot of neuro centers here in Ireland. So I don't know if there is any evidence against that one, if you agree with me. The second point, I will say all my point and then give you the mic to answer all of them. The second point is there is a question about the treatment on how to induce hypertension. So the old treatment for high ICP or subarachnoid hemorrhage causing high ICP is the triple H therapy, which is hemodilution, hypertension, and hypervolemia is not of any evidence now. So it's only the hypertension is the only evidence-based practice. And what is the degree of hypertension? What is the target map? This is a big dilemma. That's to my knowledge. So how to use, what to use to induce the hypertension? Is it noradrenaline? You need to put a central line and the neck manipulation and the central line position, use it femoral or internal jugular. All this is I think it's dilemmas which were never evidence-based practice or there's no enough evidence. And if I have any question here, Dr. Amr Safwat, is what is the role of ultrasound? You know, I'm an ultrasound man. What is the role of ultrasound? And the last comment before I finish this talk is we need to differentiate between the subarachnoid hemorrhage of medical etiology or a bleeding aneurysm versus subarachnoid hemorrhage from traumatic brain injury. So there is no rule for nimodipine at all for subarachnoid hemorrhage of traumatic brain injury origin. And that's a completely different kettle of fish if we compare that to an aneurysmal bleeding. This is the one we are required by all evidence to start nimodipine. And even if the patient is hypotensive, you can use nimodipine 2-hourly or nimodipine infusion or whatever, but you have to use the nimodipine in any way, but you have to have the nimodipine. So it's one or another, so it's completely different. Just to clarify that for the juniors colleague. So I'll come back to my question. What do you think about using ultrasound? Does ultrasound have any role stroke patients?
The best person to answer this question is you. So kindly proceed.
I agree with you, Dr. Amr. يعني I think Dr. Walid open an area.
Yes.
You can give us what is يعني new guidelines about this or the use of ultrasound in such situation, Dr. Walid. يعني you can give us. Yeah.
I'll just go quickly through them. Like if we're talking about a patient with ICP and impending herniation, optic nerve sheath diameter is a good tool to follow up instead of taking the patient to CT every couple of hours. So its sensitivity and specificity is not that bad. It's a good one actually. And if we're talking about subarachnoid hemorrhage and cerebral vasospasm, there's a very good rule of transcranial ultrasound and Doppler on the middle cerebral artery, and we call that a Lindgard ratio. If we compare the speed or the velocity of blood in the middle cerebral artery and compare that to in the internal carotid artery, if you have a good baseline on the patient, you can trace that. And if this ratio changed after 24 or 48 hours, this is an indication that the middle cerebral artery has a vasospasm. So you can increase your nomidipine, or you can start hydration of the patient, or do something to prevent the spasm. And if you want to go for CT, this will be like increase the pre-test sensitivity and specificity. So it's a good tool again to use this one.
The velocity more than 200 centimeter per second, or is the
I think cut off cerebral vasospasm.
Yes.
So, but you need to use that as a Lindgard ratio, because sometimes the high speed is coming from the carotid if the patient himself is hypertensive.
Has carotid problems.
Yes. So we still need to differentiate, and the best thing is to have like a baseline. I'm sorry for my interruption, and it's just my thoughts.
Of course.
I wanted to share with our junior colleagues.
Thank you very much, Dr. Walid. Still, we have some questions, Dr. Amr, from our colleagues. Is there any difference between the hypertonic saline and mannitol in the management of stroke-related brain edema?
Some centers now are recommending the use of hypertonic saline more than the mannitol.
So each one has his advantage and disadvantage, right? Okay. Is the CT conclusive in the first 24 hours in the diagnosis of the brain insult or MRI?
The CT might be normal in the first 24 hours for strokes.
Ischemic strokes, you mean, right?
Yes, I'm talking about ischemic strokes, of course.
Yeah, sure.
Because the hemorrhage will appear early. But what I mean that the MRI, of course, would be better. But as we said, the first treatment of choice is the first investigation is to send the patient to the CT.
In a patient with acute ischemic stroke, do we use aspirin, ticagrelor, anything, or what besides the other? What are the drugs we can use immediately?
Yes, we can give a loading dose of aspirin of 300 mg. But first we have to decide if this patient is going for thrombolysis or no.
Yeah.
Because if thrombolysis, we better delay the start of the antiplatelet treatment.
Okay. I think we covered all the questions here. Lastly, I thank you very much, Dr. Amr, for this.
Thank you, sir.
Lecture. Thank you, Dr. Amr Hashim. Thank you, Dr. Walid. Thank you, all the attendees. It was a very nice night and presentation. Thank you, and hope to see you in the next presentation. Thank you very much.
Thank you, sir.
Thank you. See you.